surgery.
Good evening to everyone. Thanks the organizer for this beautiful congress and opportunity to share data and the project and creating new partnership. Let me start. Gastric cancer is the fifth most common cause of cancer death worldwide, with over 1 million of new cases detected annually. Surgery is the primary curative option, and 25% of patients survive after 5 years from surgery intervention. In the last 2 decades, the increase in the use of mini-invasive surgery platforms has revolutionized the way of operating. Indeed, the surgeon is able to teleoperate separately from the bed of the patients with a console allowing for an enlargement and a 3D vision of the operative field and anatomy of the patients. And moreover, the easier controlling of the trocars and the higher degree of freedom of the instruments allow to overcome several limitations of conventional laparoscopy. The importance of the mini-invasive surgery procedures is clear from this graph, which show the provision of the coming to the market of robotic platform from 2024 to 2029 that is going to increase of more than 16%. In Florence, the Careggi Hospital is a center of excellence for gastrointestinal tract mini-invasive procedures, and in this paper, collecting the number of interventions made with mini-invasive platforms from the centers of all over the world, Careggi Hospital participated with the highest number of cases, interventions with mini-invasive procedures on gastrointestinal tract. In Florence, we have the Da Vinci robotic platform, which allows the use of Indocyanine green. If you can start the video from the, please. This video is showing how this tool at the disposal of the Da Vinci platform allows real-time switching from bright field to fluorescence thanks to Indocyanine green, which is a molecule injected in the patient the day before surgery and that is drained through the lymphatic vessels, allowing a lymph node mapping so that the surgeon can identify all the lymph nodes near the lesion. Moreover, it helps for the control of anastomosis as well as checks the vasculature structures. But unfortunately, it is not contrast agents which can recognize the tumor. Indeed, it's an untargeted contrast agent. So the limitation is that it's not possible to discriminate from tumor tissue and the healthy tissue, and it's not possible to discriminate metastatic and non-metastatic lymph nodes, leading to the resection of all the lymph nodes near the lesion by the surgeon during intervention. And this leads to an increase in the intraoperative risks for the patients, an increase in the surgical time of resection, increase in the hospital stay for the patients after the intervention, and a high risk of recurrence because of the risk to positive margins residual after intervention. And all of these things can lead to an increase of the costs for the hospitals. So our aim was to develop a fluorescent contrast agent that can clearly recognize a tumor-specific marker in order to discriminate between tumor and healthy tissue, and also for the discrimination of metastatic and healthy lymph nodes. for having a more precision surgery interventions. And to do this, we started from searching for gastric cancer markers in the literature, and then we validated those markers on cell lines, tissue from patients, and on organoids derived from patients' biopsies. First of all, we searched in the literature for gastric cancer markers, and we selected 5 markers that were described to be expressed on the cell membrane for assessing the real-time imaging. And we focused our attention on CEACAM5, Claudin-4, IPCAM, OLFM4, and PIGER. We assess their expression on Western blot, first of all on gastric cancer metastatic and non-metastatic cell lines, comparing the expression of the markers with healthy gastric cell lines. But unfortunately, only CEACAM5 and Claudin-4 were not expressed by gastric healthy cell lines, enabling a clear discrimination between healthy cells and cancer cells. So we decided to focus our attention on those 2 markers. So we started to collect tissue from patients underwent surgery in our center, and we fix in formalin and then embedded in paraffin, and we stained for Claudin-4 and CEACAM5 on immunohistochemistry slices from the tissues. And as you can see, Claudin-4 was highly expressed on tumor tissue, but also was highly expressed also in healthy tissue. As you can see in the histogram, where we quantified the signal of Claudin-4, so that it was not possible a clear discrimination between healthy tissue and tumor tissue. But on the other hand, CEACAM5 was highly expressed in tumor tissue and not, or to a lesser extent, in healthy tissue. So we decided to focus our attention on CEACAM5, and we go on only with this marker. So we perform immunofluorescence staining of CEACAM5 in green, and we confirm the data previously obtained. And at higher magnification, it's possible to appreciate the localization of the signal on cell membrane. In the same time, we set up an organoid model. Organoid are 3D structures derived from biopsies of tumor tissue and healthy mucosa near the lesion from the same patients. So the biopsies were digested in vitro, and then the cells were plated with a cocktail factor of cytokines and growth factor, and the cells started to organize themselves, recreating the organ of origin, resembling the functional unity of the gastric tissue, and we use it as a model for marker validation. And at last, we perform immunofluorescence staining on the organoids, and CEACAM5 is highlighted in green, and in red you can see the phalloidin, which is a cytoskeleton marker. And we found that, again, CEACAM5 was highly expressed on tumor tissue-derived organoid and not, or in a minimum part, in healthy tissue-derived organoids. So we can conclude that organoids were a good model for the testing and validating of our markers, because they reproduce the tissue organization, the biological composition, and the patient's genetic background, including the expression of the markers. And among the 5 tested, CEACAM5 is a promising marker for the discrimination of tumor and healthy tissue. So what we are doing now is the developing of a fluorescent molecule which can selectively recognize CEACAM5 marker that could be a good tool to be tested in vivo and maybe applied to precision surgery during robotic gastrectomy procedures. So I want to thank Professor Fabio Cianchi, who is the PI of this project that is a part of the Spoke 9 of Tuscany Health Ecosystem. Thanks to Professor Amedeo Amedei and his group, Sara Peri and Tommaso Mello, and of course, thanks to you for your attention. I will be here today and also tomorrow. If you have any further questions, I'm available. Thank you.
Any questions from the audience?
I have a very quick question. In surgical robotics application, as you presented, do you know if there are already simulators about that can be used to train the surgeons?
Yes, there are simulators. You have the possibility to stay at the console and only simulate, because there are programs on the console that can help you to just move the robot arms without operating the patient.
And only software?
Yes.
Only software, not real or mock-up, physical mock-up?
Ah, physical bodies? No, I don't think. No, there are not. Thank you. Thank you.